Muchas gracias, Fernando. Buenos dias. Thank you, everyone, for being here today, and thank you for the event hosts for the opportunity to speak to the community, and thank you to HL7 Argentina for this wonderful opportunity to come visit your beautiful country. My presentation today will be about the future of interoperability and the opportunity for us to take interoperability data and make that data even more useful by allowing us to use the data for quality measures and metrics so that we can start to measure what we do and ultimately bring about the learning health system concept that we all believe in. In today's presentation, I will be discussing the clinical quality language and the aspects of the FHIR standard and how we use FHIR to leverage this data. We'll talk about the learning health system and where the FHIR specification and implementation guides are supporting the development of the learning health system, as well as give you some insight into the future of FHIR in this next release, R5, and then talk about opportunities to use FHIR more broadly. This is a common description that we like to use to represent the learning health system. It is a virtuous cycle of the gathering, analysis, and implementation of information, as well as reporting that information. Of course, we start with research and public health surveillance. We develop guidelines from the what we find as being best practices. We do our best in putting those guidelines and this information in front of the clinicians as part of clinical care so that they can use this information as soon as it becomes good evidence in the care of patients. And then we want to measure how well we're doing it so that we can report it back and find opportunities to improve. Today, this learning health system is a very slow cycle. The estimate is somewhere between 10 and 17 years from the time information becomes good evidence to the time it becomes best practice and commonly used in practices in healthcare. We need to shorten that cycle in order to improve the quality of care that we deliver to patients. And through the course of this presentation, I'll start to build this on this slide by demonstrating a number of concepts and components of the FHIR standard that support the learning health system. So this first part that we're going to talk about is QI core, the center. QI core stands for Quality Information Core Profiles. QI core is part of the broader components of the clinical reasoning module in FHIR. So if you've been learning about FHIR, you see that the 5 modules ranging from infrastructure to administrative resources to financial resources to clinical resources. The clinical reasoning module, it brings that all together so that we can actually combine the information and then use it in exchange and care. So the QI core implementation guide is a representation of a large number of FHIR resources at their base, but also built upon the US core profiles, which is a set of profiles on the base FHIR resources used in the US, but we can imagine other countries adopting similar principles so that within a country or within a region, we all use the same representation of common resources, but in a way that's important for that region. So those include the patient resource, observations, allergies and intolerances, medications, things like that. What the QI core implementation guide is to take those resources and add more data elements, or in FHIR, extensions, and create these new profiles. These profiles support additional information that may be important when we want to use that data for clinical care. And why that is important is that the base FHIR resource is a very general resource. Like the patient resource may represent an individual very broadly, but a QI core patient profile may include other things like military status or military history, in case we want to be able to track exposures to chemicals or other things. So by adding these extensions, it allows us more data elements that can be used and exchanged when we want to do clinical decision support. It's supported by the Clinical Quality Initiative work group within HL7, as well as a number of HL7 work groups. It is based on the US, the FHIR R4, as well as the US Core version 3. So for this community and this audience, we could envision extending these QI Core profiles and adding or removing extensions as you need in order to do clinical decision support. So this guide is all about how do you represent the data. So as I mentioned, this clinical QI Core is part of this clinical reasoning module, along with these other modules. And why this presentation may be very helpful and important at this time in our journey in interoperability is that we've gotten really pretty good in HL7 and the community at representing this data up here. And there aren't a lot of new FHIR resources being created. Many of them, the common ones, are very mature. And so our opportunity is to take that information and make it useful. And the way we make it useful is to use the clinical reasoning module and the components in FHIR for that to enable the representation, the distribution, and evaluation of knowledge artifacts, and using these knowledge artifacts to in part of patient care. So we'll talk about some of these resources. So you're already familiar with many of the FHIR resources. The clinical reasoning resources leverages all of those base FHIR resources along with some additional ones that help us in being able to represent data. Things like this activity definition allows us to represent what kind of activities that can be done in the course of patient care. A library is a extension or resource that allows us to capture this clinical information in a computable form. If you're a technology person, imagine being able to take SQL for relational databases and collecting them into a library. We use this library to carry CQL as a knowledge artifact. Within here, we also have a number of resources we use for measurement, either quality measures, or we're beginning to look at them for using for value-based care metrics, as well as risk adjustment. And risk adjustment may be more of a US concept, but the idea of being able to measure something about a population of patients, and that we apply the same measure across this population and use FHIR and CQL to do those calculations. We have plan definition, which allows us to represent a course of care and the requests, procedures, and outcomes. And we have a couple of resources, evidence, citation, and evidence report, that helps us represent concepts that are in research studies, so that now we can try to represent research studies and the findings in FHIR, so that that information can be interoperable and more easily compared to other studies. I've done a lot of work in the past teaching evidence-based medicine to medical students, and one of the challenges is to gather the research together and help them understand how you analyze them, because each study is just a little different and the data is represented a little different. And so these FHIR resources help us to be able to bring that data together and aggregate them and analyze them more easily. So along with those FHIR resources, we also have these extensions or additional data elements. I won't go through them all, but really these elements allow us to have components in FHIR to both represent data as well as to leverage that data in clinical decision support. Next, we're going to talk about the CQL library. And the CQL is really, again, a way of taking FHIR data, resources, as well as data elements, and representing them in a form of logic. Again, for the technical folks who've done a relational database, think of CQL very similar to SQL in the ability to take data from a database and do to search and do calculations on that data. So again, clinical quality language is shortened as CQL. So if you hear me say CQL, that's what I mean. And why do we need CQL? Some of you may be familiar with other clinical decision support languages like ardent syntax. And for a given hospital, you can take that ardent syntax and customize it pretty well in your system and be able to work with your data model. The challenge with ardent in the past is what we've called the curly braces problem, where the logic is explained, but inside the curly braces, the implementer at the hospital or within a system has to apply their own data model and data elements to that part of the syntax. And as a result, the logic from a human standpoint can be shared really well, but it's not as interoperable as we like. But with the use of CQL and the use of FHIR, we can use FHIR for the data and accessing the data and the data elements, and in the CQL, use those same data elements in the logic. That makes for these artifacts much more easily shared between two hospitals or two systems that use the same FHIR as the base of their data representation and CQL as the basis of the logic. So we're improving on not only interoperability of data, but how we leverage that data for logic. It also allows us to further specify the clinical domain. So you can write CQL for a specific domain. If you want to create cardiology algorithms, you can write them in CQL. And with CQL, you can create definitions for a cohort of patients, which is really great. When you do quality measures, you're looking for a particular population. And then you can also share these algorithms with others. In the US, we are on this journey to create quality measure representations using using CQL. So with quality measures, you have to define your initial population of patients. You have to also define within that population who is excluded. And then you can also define what is the data that supports that the quality measure has been completed. So one example is colon cancer screening. Broadly, anyone over 50 in the US is eligible and should get screened for colon cancer. That's, we'll say, our initial population. Then you could say if that person has had a screening previously within a window, you can exclude them. Or if they've had their colon removed, you can exclude them. Or if they are in hospice, you can exclude them. So you can define the population, and then that tells you who should have had their colon cancer screening. And from that, you use CQL and the definition of the quality measure to say, those individuals should have had one of the colon cancer screening tests, like a colonoscopy or a blood test or other tests. And you can look into the record using FHIR to find evidence that that has been done. And when you find evidence, then you can include that that person has had the right study. And ultimately, instead of having a person look into the medical record, you have FHIR and the system retrieving all this information. And that saves a lot of time and reduces the burden on administrative staff to find this information. And by sharing the CQL, we all share the same definition, but each system can automatically execute it using one of the expression logic models or via a platform like Drools or even SQL or other methods. So it makes sharing of clinical decision support artifacts and knowledge artifacts much more interoperable. We can include within the CQL code system. So we're all using SNOMED in the US, but if you use SNOMED within your country, you can define quality measures and other clinical decision support using SNOMED. We can use value sets just like we do in other parts of FHIR by defining a disease grouping so that we can group all of the like diabetes or sore throat, all these codes together. And of course, we use coded terminology, which is extremely helpful for more specifically defining conditions and medications. And then we define the logic here using these definitions. So you can define, in this example, a flexible sigmoidoscopy, this type of test for colon cancer, and know that it's completed because they have it's been performed during a period less than 5 years before the period that you measure. So all these are individual logic that you can define using FHIR and using CQL, and then execute this logic on a database using a CQL execution engine. So here's some additional examples. You can retrieve data from these FHIR resources. So you can retrieve specific values for a patient and then convert those values from imperial units to metric units. We use a lot of dates, and so you can convert dates using CQL. And this is very helpful because one of the components that we've done is not only looking backwards at how well an organization has performed on a quality measure, we can actually look forward. So I might be able to design a CQL script that says, for colon cancer screening, tell me who will become eligible next month or in the next 2 months or 3 months. By knowing that, I, as a provider, can reach out to those patients and get them in to be seen by their provider and have that scheduled before it becomes due. So as a hospital system, I can improve on the quality of care by anticipating what patients need. And then I can also improve on my own quality measure scores by doing it, performing the service and the screening as soon as possible, so that it's completed by the time I have to report on it. So one example that will be linked in the slides that will be shared is cervical cancer screening. And this is an important screening for women, and has done this says colorectal cancer screening, but the link is for cervical cancer screening. And it's really important because it allows us to define this library. So we can reuse this library of cervical cancer screening. And if the guidelines change, we can update that. And what it does is that it uses a set of FHIR helpers that allows us to set up how we can retrieve data via FHIR, and then we can define certain components of it. We define what an encounter or visit is. We define the fact that we use SNOMED for many of our values. We can define the type of tests. The HPV is the cervical screening tests. And so we define them as a set of a value set, as well as a PAP test, which is another type of test. And then from there, we can define the period that we want to look at. And from there, we define these components, and then we apply these filters and calculations on a FHIR database and retrieve that data via FHIR operations, search and retrieve, which I believe you've learned in some of the other classes. So this builds very much on what you would already know as a FHIR implementer. These are some additional components. In the US, we would apply ethnicity and payer or race. Of course, you only apply this measure on a female. So it's important to note that when you go to retrieve the patients that are part of the population, that their patient resource and the element for gender is female, so that you know that you're not retrieving males, and that you would look for female patients that are between the ages of 23 and 64. So this is just a simple example of how you would define the initial population and the denominator, and this exclusion here is for patients on hospice or a patient who may have had their cervix surgically removed. So as you can see, this CQL is very much human readable, and individuals can be trained on FHIR, as well as understanding how to create quality measures, and then work with CQL to define these quality measures using FHIR. So I think the big opportunity and the big challenge is to really train quality measure developers, as well as others who work with knowledge artifacts, to use CQL. The good thing for the community really is that this has been very well tested over the course of the last 6 or 7 years in FHIR. Even as the community was still learning about the basics of FHIR, there was a smaller set in the community working on this more advanced approach to FHIR, because we knew we needed it. So the things I just described are written in the CQL implementation guide. Like other implementation guides, defines the specification itself, and how to use it, and what are the FHIR components. And we also have reference implementations. As we have been working in HL7 and this new implementation division that Diego Kaminker and I lead, we are stressing the importance of having not only a specification where human analysts and developers can read, but also representations of that specification in working code. And I'm proud to say that the reference implementations for CQL are very advanced. They're very robust, and are very high fidelity, in that they represent a large amount of what is in the clinical reasoning specification. So because of that, we are able to test quality measure resources using sample data, and really test out that execution of these scripts, and really prove out how useful they are. In the US, there is a division, the Agency for Healthcare Research and Quality, that is promoting the use of CQL and CDS, and they support a webpage, the CDS Connect, that allows folks who are looking to try to learn more about CDS and try out their own CQL to be able to go in and practice in authoring CQL. So it's a very useful resource. It's both useful for those looking at quality measures, as well as those who want to develop clinical decision support for at point of care CDS. This is a little screenshot of the authoring tool. The authoring tool is more complex below, but it has a very nice user interface that can help a user use the interface to define, let's say, the patient age, gender, in something much more simple, and then it would generate that CQL like you saw earlier for them. I think that will be an important set of tools that we need to develop more of, in order to help make CDS authoring more easier for those who aren't necessarily technical folks, but they have the knowledge necessary to author CDS. So with this, what can we do? So we have now the ability to represent clinical data and research data using QI Core. We have the ability to script the data and do calculations on that data, to be able to search for specific components of that data. So one of the aspects of what we're working on, it's still relatively early days, but they have made good progress, is called evidence-based medicine on FHIR. And the concept here, really starting with the EBM on FHIR work, is to work with the various groups, and in particular the biomedical research and regulations work group within FHIR, to look at the research and see what are the common things that every research paper has that we could represent in interoperable artifacts, and then create an ecosystem for the research community to represent that data. Today, we write papers, we submit data to support those papers, we calculate p-values, But in a future ecosystem, we would want to be able to define the patient population that the research was on, just like a measure does, define what data is captured in the research study, what are the common terminologies and code systems that could be used to represent that data, and a set of tools for converting that clinical research data into FHIR-based data. Ultimately, we'd like to see all of this kind of captured in FHIR, analyzed in FHIR, and then represented via FHIR. And that's will be a future time, but I think we're well on our way to doing that. So we have a number of evidence report resources that allow us to represent common components of a research study. The population, statistics, and knowing the evidence quality, things like p-values from the research. We also want to continue to leverage common terminologies like SNOMED, LOINC, and then use those in the representation of the data as well as in the studies. We want to be able to put the studies in a type of FHIR repository ultimately, so that they can be retrieved more easily and more aggregated more easily. When I was in training and teaching students 20 years ago, we were using the Cochrane Collaborative, which had a lot of really smart researchers gathering research data and then putting it all together into something that could be easily digested and understood by a clinician. And that was a very time-consuming process to gather this information and to compare studies to make sure that they're not only good quality, but that they can be comparable. So hopefully with the use of FHIR and interoperability, we can do this more quickly and again, shorten that time from the time that clinical evidence in research appears and how it can be used in day-to-day practice. And we have some specific activities around this, mostly around COVID, because there was a very important near-term problem that we're all facing. So this is one aspect of how we can represent the learning health system and specifically clinical research studies in FHIR. Excuse me for just one moment. So in the learning health system, we take clinical evidence from research, but then we have to make it more digestible. We figure out where the quality of the research is and how it can be directly applied to clinical care. Today, that's done typically by professional societies of the different subspecialties, cardiology, internal medicine, and such. They gather that data. They analyze it, they look for the evidence, the quality of the evidence, and then they provide guidelines. And that takes a long time to do that work. It's a very labor-intensive collaborative work. And as a result, it again delays how quickly we can get that information into the hands of clinicians. So we have a project called CPG on FHIR, or Clinical Practice Guidelines on FHIR, that looks to leverage, again, that EBM on FHIR work to create clinical practice guidelines. For those of you who read clinical practice guidelines or who have developed clinical decision support based on these guidelines, you know that those guidelines are mostly meant to be read by humans. There's a lot of flexibility in the language, like should or may or up to the clinician. Those are important to do because the flexibility needs to be there for the clinician to apply that guide for their specific patient. But what happens is that flexibility is difficult to represent in a computable language. And so we really want to take the parts of a clinical practice guideline where the evidence is strong and the actions or the set of actions that are supposed to happen get well defined. So a simple example might be a patient first time diagnosed with hypertension with a certain ethnicity should be given a certain medication, say hydrochlorothiazide, a first layer kind of medication. So as much as we can define the guidelines and the individual patient factors in FHIR and computable language, we can then define the expected action in CQL, and then define what is the outcome, a particular kind of order, a study, a medication, some other intervention, and then define what outcomes that we would use to determine whether or not it's effective. And that allows us to represent a clinical guideline in a closed loop for the patient. So there's some information for you around clinical guidelines, and there are a number of examples in this implementation guide, so you can see how these guidelines are represented as FHIR resources and as CQL. So moving along, so we have evidence. The societies have put together clinical practice guidelines, but how do we put those guidelines in front of the clinician who is caring for the patient and who may not be tracking the most recent evidence or the new evidence? So we have a function developed within the FHIR community called CDS hooks. And CDS, again, is a clinical decision support. And the hook is a hook, a trigger kind of hook within an electronic health record that happens during the course of care. So we have a number of hooks defined here on the left-hand side. The most commonly used and the most mature hook is this patient view hook. And so I open a new patient's chart, and it would then, the hook would tell the EHR to go out to a CDS service. That service might be within the hospital or the organization I work, and that CDS service has knowledge in there. And that knowledge can be used by the EHR, and the EHR can send some information to that CDS service. It can say that the patient is a 51-year-old male who is otherwise healthy, and the CDS service, based on how it's configured, can return information back to the clinician as what we call a card. And that card can provide information. It can provide a link to other information, a web link, or can provide a link to a Smart on FHIR application and provide very specific information back to the clinician about the patient in front of them. So we've used this for quality measures. So you can imagine a patient walks into the office, is seen, open the chart to start a new encounter, and the card that comes back tells them that, oh, this 50-year-old male is due for their colon cancer screening. It's November, and so they should get their flu shot, and you should talk to them about other health and safety concerns. That's helpful as a clinician, and I'm an internist and a pediatrician, because you get so busy, you want to do the right thing, but there's so much information to keep track of. And you also not only need to know what the guidelines are, you have to apply them to the patient. And this CDS service and CDS hooks allows me to combine that and know what I need for my patient in front of me. So not only can you tell me what is I need to do, but you can also help me to do the right thing by providing this information and providing other additional applications like a Smart on FHIR application, which I can use within my the workflow to deliver care. So these are all components of FHIR that can help improve with clinical decision support. So now I've seen the patient, I've been told what I should be doing on the patient, I've been delivering the care, and now I'm getting measured on it. And I want to know that, or those who pay me or the federal government wants to know how well I'm delivering care. And so they're going to measure the quality of care. And in the US, we have been transitioning from very manual abstraction of data from the EHR to the CDA, the HL7 CDA quality measure report. And now we are transitioning into using FHIR to do this reporting. And the good thing is that it leverages knowledge and work that's been done in the past, but significantly, it converts things that were well structured but not so computable into FHIR components, the QI core profiles, as I mentioned. and the representation of the quality measures in CQL continues, but now instead of in the old framework that we use, we will use a FHIR electronic clinical quality measure framework. And instead of using the old version for reporting that used the QRDA, the quality reporting document architecture, and this particular data model, we'll be using FHIR. And the benefit here is what we believe to be the broad benefit of FHIR, in that this old paradigm uses documents. You create a document when you want to do a report. That's helpful, but as with any data, once you create a document, that data gets old. Sometimes it gets old very quickly, sometimes it gets old very slowly. But by using the FHIR paradigm, you have just-in-time information and you can update it more quickly. And that's the power of using FHIR and APIs. And the other power, as I described before, is the ability to project forward and do what we've been calling gaps in care, looking at a patient population and finding out who's missing screening tests or immunizations or other treatments. We couldn't do that easily in the past, and we certainly didn't have the interoperable tools like CQL to do that well in the past. So the implementation guide that we use in this model is called the quality measure IG. And think of it as a way of representing quality measures. So it uses CQL to provide the terminology and all those parameters about the initial population, as well as how to score that quality measure. So you can take the data and then you can define whether or not you've scored high or low. And that's important information for the provider to try to anticipate and improve, as well as important for people who are overseeing those quality measures to have a way of comparing one provider, organization, or individual to others in a very uniform way. And using this IG and representing the quality measure in FHIR helps to do that. And then on top of the representing the quality measure is a framework for requesting and receiving or pushing the measure report. So some of the work that I've been able to lead in HL7 and a group called Da Vinci is to define this framework, the Data Exchange for Quality Measures framework. And this framework represents how a provider system, a payer or intermediary, and a measure authority, the federal government or others, can use FHIR to request quality measure data or to push quality measure data. And it allows us to create these measure reports. And the measure report can be at a single patient level, so I can find out all the applicable quality measures for that patient and know what they're missing. Or if I need to report on how well I do across a population, I can do a population level measure report. So again, very useful, not only for quality measures, but the same paradigm we're actually using for looking at risk factors and ultimately using them for, in the US, value-based care and how to measure performance on a value-based care contract that then can be translated into how provider and provider organizations are reimbursed. So this, sorry, this is messy. It wasn't messy before, but it's a couple of the differences between a individual measure report and a summary or population level measure report. I'll fix this when we send it out. So again, we've now covered getting from evidence, representing that, put it in the clinical care, and then reporting on it. And sometimes these reports aren't always around quality measures. Sometimes we do surveillance as we do in public health. So we have this electronic case reporting guide for public health that we are harmonizing with some of the other reporting paradigms, but it really helps us to define metrics that hospitals can use for reporting, because they're not always metrics that are quality measures. So you can find out more about that in this guide. So we've covered now the whole loop of the learning health system. Some parts of the loop are still early stages, the EBM and CPG, and some parts are actually very mature. The CDS, the core aspects, the CDS, the quality measures, and DQM are very, very mature. And so we are on this journey. And to achieve this journey really is to get more and more health systems and countries and regions to adopt FHIR so that they're all using the same paradigms that I just described in this presentation and using interoperable artifacts. And I think the community here in South America and along your journey will get the benefits of all the learnings that we're doing in these early stages in North America for advancing this work. And so we hope that you'll be able to learn from this presentation, become interested in CQL, and then maybe engage in a community here to work on opportunities to apply these principles for this community here. And in the last little bit, I just wanted to note some things about the future. Currently, we've just finished actually our balloting of the R5 or version 5 of FHIR. And it's really just a maturation of a number of things that were in version 4, as well as addition of one significant component called subscriptions, which will allow us to monitor for the creation of new FHIR resources. So think about it as a kind of a polling or a push mechanism to know when new data is available. But the vision that we have in HL7, and I think follows very well with the broader evolution within the internet and the web-based community, is that we have more and more of the use of APIs. We have more cloud-based implementations of healthcare technology, so that it's not living in servers that are local. It allows us to not only exchange data between one entity and another, but really leverage that data for workflows and for patient care. I like to use the example of travel and how travel is from the days of a travel agent to today has really transformed the way we book travel and follow the progress of our travel using apps. I think that's really going to be happening in the healthcare community and individuals as their data is more readily available on mobile devices and on the web. Of course, always securely and with the appropriate levels of privacy. But the advances into R5 will allow us to improve in the way we store data, we exchange data, we look to improve on using FHIR for voice to text, as well as to engage patients and populations better with FHIR. There's many individuals who need care don't necessarily go to a hospital or facility. We have individuals going to the community. And so FHIR allows us to build applications that can collect data on mobile devices and store that data securely and deliver the care where the patients are. And I think that's going to be really important as we try to engage more rural communities in healthcare. And I think the advancements in satellite technology and internet via satellite will help that effort tremendously. And then I think this provides an opportunity to advance today's EHRs, as well as to develop new functionality and new possible opportunities in EHRs. For those of you who know Expedia, the travel platform, it's now just over 25 years old. And in the early days, that was the only one, but over the 25 years, we have dozens of these travel platforms. And they use much of the same underlying data from airlines and hotels and such, but what they've been able to do is to enhance the user experience with that data. And I think we have the opportunity to do that in healthcare, to improve the user experience for the clinicians and patients, as well as improve care for all of these patients. With that, I want to thank again for the invitation to be here. I hope this was a helpful presentation, And I will hand it over to my colleague, Diego Kaminker. Thank you.
Thank you very much. An amazing presentation. Thank you.
Thank you.
We have some comments in the chat. Carlos. CPG will be great to accelerate the creation of clinical decision support. Bypassing this mainly hard for clinicians, which is trying to figure out what I need to change in my practice. Any comments about that?
Yes, I 100% agree. When I was in practice, I practiced for about 10 years in internal medicine and pediatrics, and trying to keep track of what the latest immunization requirements are or the screening requirements are for patients was very challenging. So being able to have that knowledge sent to me, that they know the patient in front of me, whether it's a child or an adult, and whether or not they've had their immunizations in the past, being able to bring that clinical decision support will actually improve the quality of the care that I deliver and make sure that the time I spend with my patients has a tremendous value, knowing that they only spend 15, 30 minutes with me once a year or once every few months, and I want to be able to deliver as much as I can, and the CDS will certainly help that. And it helps, maybe not here in all the communities in South America, but in the US, by delivering better care, it improves my performance metrics, and on occasion may improve my reimbursement as well. Thank you.